At the last collaborative-wide meeting, I discussed both the chest pain modules, very appropriate after we had Dr. Mahler, and also our peds respiratory. So this time we're going to focus on our remaining two modules, and we're going to start with the head injury. So our head injury module is the only module that encompasses both adult and children. It is built to assess for the minor traumatic brain injuries, and the module itself contains 27 questions. It's our longest module. The questions themselves were devised from the Canadian Head CT and PCARN, and the final diagnosis of a closed head injury was not necessary to actually qualify for abstraction. The cohort assignment is designated by ICD-10 diagnosis codes for head facial trauma or chief complaint of a head or facial injury. The superficial injuries are not counted, such as bug bites, dog bites, minor lacerations, those type of things. They're all excluded. The cases are also abstracted whether or not a head CT is performed. We do review all notes of the medical documentation. We look at provider notes, nursing notes, EMS notes. We include them all. We also determine the mechanism of injury, dangerous for adults and severe for children. We pretty much do follow those head CT guidelines for that, as well as the PCARN. We also look if a GCS was performed, and if so, what's the score? So as an overview of the module itself, so that everybody can see what the abstractors are looking at on a day-to-day basis to do this, the first 9 questions of the module itself can stop the abstraction based on the answer. They're exclusionary questions, so if it makes it through all of those 9 questions, then it will continue to the full abstraction. So the first few questions, the first 9 questions are built on, was the injury greater than 24 hours? Because if so, it's excluded. So anything less than 24 hours, and I'm going to talk about that timing a little bit later. Was the injury itself caused by blunt trauma? Also, is the patient on antiplatelet or anticoagulation meds? And of course, do our prior information from Dr. Klein, I did not say blood thinners. It's strictly anticoag or antiplatelets. Was also the trauma service either activated or consulted, because that will also exclude it from this module? Is the patient pregnant? Do they have a bleeding disorder? Is there a suspicion for a non-accidental injury? Does the patient have a ventricular shunt? Or do they have some type of brain tumor, lesion, intracranial mass, AVN, something like that, that would also exclude them. So if they make it through all of these questions, then I'm just going to show you a sampling of some of our questions from the module itself. I've highlighted a few of these because these are the areas that I find we have a little bit more difficulty finding full documentation. So all the questions are very important, but I just want to bring your attention to a few of them a little bit more heavily than the others. So one of the questions is there is documented history of a cognitive deficit, except for when they're acutely intoxicated. It's very helpful to have a baseline cognitive definition of what this person, if there's A&O times 3, or if they have a baseline dementia or other cognitive deficit, it's helpful to know where we're starting at, because we do need to know if there's been altered mental status or amnesia or something, and we need to know if it's different from their baseline. Of course, we always ask if the patient has a headache, pretty obvious for a head injury module. Then we also look at, you can see it's bolded, the documentation of whether they have loss of consciousness with the associating injury or not. That can be a little bit tricky. That's one of the areas that I find through all the SNAP reviews, the audits. There's varying documentation on that, because of course we all know patients throughout their ED stay can say multi things. So they'll tell the nurse one thing, they'll tell the EMS something else, and then they'll eventually tell the provider a completely different story. So it's helpful to have all the documentation a little bit more consistent, but we know that's not always possible. We're also looking if there's documentation of vomiting since the injury, and if it's happened more than once. We also look at, is there short-term memory deficits, the amnesia since the injury? So again, that's where that baseline cognition comes into. And do they have a documentation of altered mental status, again, since the injury? So a few more questions that we have, because again, this is the long module, is do we have documentation of a basilar skull fracture? These next few ones are actually very important from the PE, from the physical exam standpoint. So that's where we get some of these answers. So we're looking for signs of a basilar skull fracture. Do they have documentation of an open or depressed skull fracture or tense fontanelle? Does the patient have documentation of either an occipital, parietal, or temporal scalp hematoma? No frontal on this one, but it's also bolded because I found there's many creative ways to talk around a hematoma. So we're trying to determine if it is or not. So I'll get to that a little bit later too. Did the patient have documentation of a seizure since the injury? And do we have any focal neural deficits? We have major cheat sheets for the abstractors on that one. And then this is always the fun one. I've been getting a lot of questions recently about this one. And about the documentation of intoxication and whether that itself lends to just an automatic head CT. So we're looking for this particular question, is there documentation that the patient is still actively intoxicated during evaluation in the ED? I'll talk more about that in a second too. So for takeaway points for documentation for the head injury module, we have a few. The first one is, when did the injury occur? Is it within 24 hours or not? So we need a sense of timing. So it's very helpful when it's like they fell 2 days ago or they just prior to arrival. Some type of timing is helpful. And also if a GCS or a PCS, a pediatric coma score, was actually one recorded. Typically in most places, the nurses do that. So it's helpful to have that listed because we do account for that. Is the patient on anticoagulants? Just because medication is on the med list doesn't always mean they're taking it. So it's very helpful when I see in the documentation that the providers address this specifically. They'll say they're not on anticoagulation or they're not taking aspirin. That's very helpful to see that, because even a single dose of aspirin, it is considered an anticoag and it will end the abstraction. So again, also with the cognitive deficit, we're trying to determine, is this at their baseline or is this new since the injury? It's pretty important. But even more important, I think, is the actual physical exam itself. We rely heavily on this section of the notes, and this is definitely by the provider. So when we're looking at the physical exam, is there the ecchymotic area, an actual hematoma or not? Is it listed as an abrasion, a contusion? There's many words to put, but do you consider that a hematoma? One example I just saw recently was they wrote that there was contusion and bruising posterior to the right ear. So what was the extent of that contusion bruising? I mean, was there swelling? Was there edema? Was it a hematoma or not? And then again, posterior to the right ear doesn't tell me, is it, occipital, temporal, where? We need to have some more specifics on that. So it's just a reminder that as you're doing your physical exam, we look at every word you're writing. And then here for this one, for the intoxication, again, we need some type of verbiage from the providers that the patient is still intoxicated. They can be later clinically sober before they're released, but at any point in the ED visit, were they intoxicated? We do not go through the blood alcohol level, the BAL, because we know that some of our chronic alcoholics, unfortunately, can have an elevated blood alcohol level, but they're not intoxicated. So there is a difference. And of course, the GCS is vital, right? As a reminder, the GCS lets us know if the patient's orientated to time, place, or person, and if they're able to obey commands. So when that intoxicated person comes in and they don't know where they're at, they don't know what time it is, and they're not following any of your commands, a GCS of 15 is not necessarily appropriate at that time. So we're going to move right on to the PE module. So this module overview itself, this is our shortest module, but no less important. It consists of 6 questions. It is based on procedure codes 71260 and 71275, which is technically a chest CT or a CT angiogram. So the qualifying question that starts it off is if the chest CT was ordered by the ED provider. If it's not ordered by the ED provider, we kick it out of our module. It's not appropriate. So we even look And again, since it is based on the ED provider ordering it, if a consulting team asks for it or recommends it, but the ED provider orders it, it is still their decision to order it, so we count it. Pregnancy itself will stop the abstraction. The question automatically populates for females in the ages group of 10 to 55. We are also looking if there is an acute PE. This is something we capture in this module. So sampling of our suspected PE module questions. Just like to point out, I like to show these. It is very, very helpful for the abstractors, for all their clinical champions to know exactly what is being asked of them. So this is very helpful that I'm able to help the abstractors get all of this out to everybody. So for the PE module question, one of them was the CT performed above done to rule out a PE? That's very important, and we'll get to that in a little bit too. Did the CT scan result in the diagnosis of an acute PE? We'd like to know. A note here that inconclusive, you can see the answers are yes, no, or inconclusive. The inconclusive on acute pulmonary embolism is not inconclusive due to poor imaging or poor contrast. It's based on inconclusive that the radiologist saw something in there and they can't quite determine whether it was acute or chronic PE. That's the difference in definition of that inconclusive. We also ask if there was not an acute PE, what was found on that CT? I did spend 5 years in thoracic surgery, so I'm pretty qualified to help the abstractors understand this section, and I'm going to go through one part of this in a moment because it's pretty important. But you can see we look at things from pneumonia, the pleural effusions, pericardial effusions, old and new fractures, pneumothorax, aneurysms, dissections, those type of things. We want to know what else was found. So the next, some of the rest of the questions that show up, we also ask if there was a D-dimer done during the visit. And if there was a D-dimer, what is the measurement unit for that? And what was the value? Was the D-dimer itself considered positive? So the takeaway points for documentation on our pulmonary embolisms are these. The most important one, and it's bolded, is because it's not always clear if the CT scan itself was done to rule out a PE. It's very important that we have it in our differential diagnoses. So if there's also, I can see as a clinician, I understand when the provider is asking questions such as, is there recent travel? Was there a pregnancy? Is there malignancy? Is there recent surgery? Do they have swelling of the extremities? I know, again, as the clinician, that most likely you're thinking, is there a PE? And you're trying to see if there's higher risk factors associated with this. But the abstractors themselves need some indication that it's in the list of differential diagnosis. So something a little bit more spelled out is helpful. I'm going to go to that next bolded point. It's incredibly helpful for the abstractors themselves if there is an actual order set that says the CT for pulmonary embolism. I've seen a lot of facilities do that, and that is very helpful for the abstractors because then we know automatically that was in your differential diagnosis, that's why you did that particular order set. Something else we do take into account, as we know in reality, a D-dimer may be done at an outside facility, a primary care office, and then when the result is positive, then they're sent to the ED for evaluation of that. So we do keep that into account, and we can include that in the module. So we allow that to be credited. And we also, a big part is we look at those alternative diagnoses on the CT scans. One of the most difficult things to understand from the results of the CTs, the radiologists can talk around what they see, right? They don't always call an opacity or consolidation a pneumonia. They always want you to clinically correlate it with what's going on. So it's helpful when in the MDM itself that you address that and you state whether you think it's pneumonia or whether it's not, and if you're going to treat it or not. It's very helpful when you address those type of things. And also if there's lung nodules, of course, we all know that they don't always have to be malignant. There's many reasons for those. So it's just helpful to know if you think it might be a malignancy, is it metastasis, because we do account for malignancies also on the scans. So those are the main points and for those two particular modules. Just again, it was a reminder for everybody to know what the abstractors are responsible for. Does anybody have any questions? Okay.
Yes, There is one question here from Dr. Davis at Henry Ford Allegiance. He's wondering if we document that we're using age-adjusted D-dimer, is that appropriate for ruling out PE in the PE metric?
We don't address that specifically in the module. That is something that we can look at, though, typically even on the back end. But it is something we're keeping in mind. And I don't know if Keith has any additional comments on that one, so I'll let him handle that. Is there any other questions for me specifically?
Nope, that's it.
Great. Okay. I'll hand it over then to Keith, who is going to be talking about 2021 for us anyway. So this is a great segue. Thank you, everybody.
Thanks, Carrie. Yeah, and I could follow up on that question. Yeah, so we don't specifically abstract that information. We abstract the value of that D-dimer test. And as Carrie was saying, on the back end, we can consider what it would look like if that was age adjusted. But we don't intentionally insert that into the way that we do the quality measurement itself, which is, as you know, diagnostic yield. For the CT itself. There may be other questions more directed to me from Carrie's section here, so I'm going to ask if there are other questions too.
Yes, we have one more here from Dr. Veeder at Beaumont Farmington Hills. He's wondering if there can be a discussion about definition of intoxication for head injury. Just because their GCS is normal doesn't mean they're not intoxicated, noting that this has been a challenge for many of us.
Yeah, I certainly recognize that. That particular point comes up quite a bit, I think, in over the years that we've been involved in this quality improvement work. Yeah, so we do collect the presence of intoxication as stated in the chart as a data field. And I would say that's largely a legacy of how we began to collect this information when we first designed the module. Realize this is going back 4 years when we were first beginning this work and MEDIC was starting up. We don't actually use that information, though, to inform the measurement itself. However, I think it's an example of how we can do our own science with the registry itself. And understand to what extent intoxication as retrospectively chart abstracted is meaningful or not. I continue to believe in the evidence myself from the Canadian original derivation of the Canadian rule, where GCS is the way to understand if somebody is altered, rather than any kind of statement about intoxication, which is challenged because there is a high degree of variability as to what that means. Provider to provider, patient to patient, it's simply an unreliable measure of what intoxication as it translates to altered mental status means. So recognize that we do collect that information, but it's the GCS. You have to have GCS. That's the way these decision rules are designed. Any other questions, Megan?
Yes, yeah, one more here from Dr. Lewandowski.
Okay.
He's noting that in the Canadian CT head rule, it defines a dangerous mechanism as a fall from 3 feet. We deal with many geriatric patients that fall from standing. Is that considered a fall from greater than 3 feet due to the height that their head falls, or does the whole body have to fall over 3 feet?
Yeah, there can be a lot of granularity in getting into the weeds, not just in this example, but in lots of other individual case examples that come up to us all the time. Carrie can speak very, very well to some of these, the examples in the PCARN rule as well. I would say specific to the Canadian rule in geriatric populations, of course, if you're over the age of 65, that's already, and you're worried about a significant head injury, that's already a flag for doing a head CT. I would say technically we adhere the best we can to the descriptions of the way those rules were originally outlined in the way they were derived. So yes, I mean, we are looking for a fall, whether it's in the PCARN rule or the Canadian rule as described in the original derivation. Now, the reality is, like, people document in various ways, and so you may not have enough information, and so you have to make some assumptions based on that documentation, as Carrie, has been alluding to all along here. So if there is a fall from a height and it's influencing your decision, make sure that you're documenting that height. Otherwise, we are going by the way the rule is described and what's in the chart. Other questions?